Chapter 8, Lifting and Moving Patients. The National EMS Education Standard competencies for this chapter will focus on EMS operations, knowledge of operational roles and responsibilities to ensure patient, public, and personal safety. That will be the focus. Introduction. In the course of a call, you will have to move patients to provide emergency medical care and transport. So majority of your job will be physical. It's a physical job, but you're also required to have knowledge and understanding and you need to know to apply skills based on your level of training. So it's a combination, but it's highly physical. To move patients without injury, you need to learn the proper techniques, which is proper body mechanics. So you need to have an understanding of proper body mechanics, how to manage weight, proper grips, the most appropriate way to move a patient, the most appropriate tool to move a patient or equipment. The wheel ambulance stretcher, this is going to be one of your primary devices for moving your patient. The wheeled ambulance stretcher, also called an ambulance stretcher or gurney, is most commonly used device. The wheel ambulance stretcher weighs 40 to 145 pounds, generally not taken up or down stairs or where the patient must be carried for a significant distance. So there are limitations to where we can move the wheeled ambulance stretcher. Now, when moving a patient by rolling, using a stretcher or other wheel device is preferred when the situation allows and helps to prevent injuries from carrying the patient. So once you are able to put the patient on your stretcher and move them and there's nothing to impede that, then you work with your wheel stretcher. Points to note: once your patient is on the stretcher, the person that is at the head of the stretcher push the stretcher. The person that is at the lower extremity end will pull. So the person that is at the head pushes, the one that is at the lower extremities will pull. The person that is strongest or need to be at the head of the stretcher. That's where the upper portion of the patient's body is going to be, and that's where majority of the weight of the patient is going to be. So the person that is stronger is going to be at the head of the stretcher. When you're moving the stretcher with the patient on it, you always travel foot first. So once you have taken the stretcher out of the unit with the patient on the stretcher, you will travel foot first. When you're going to load the stretcher into the unit, you load the stretcher by putting the head portion of the stretcher first. So those are some important things to note. Before going on a call, familiarize yourself with specific features of the stretcher your ambulance carries, and that goes without saying. So if you are a part of an organization that requires you to do EMS response, then you need to be familiar with the equipment that you're using. And there are various types of stretchers. So you need to be familiar with the type of stretcher that you're using. You need to know how to adjust the stretcher to various heights. You need to know to put it in a sitting position. You need to know to elevate the head of the stretcher. You need to know where the IV stand is. So you have to be familiar with the stretcher, how to bring down the handlebars, how to lock the wheels if it has a wheel lock. All of these things are important. You can't wait until you're on a call to try and figure that out. That's gonna make you look incompetent. General features for the wheel ambulance stretcher: head, end, and foot end. And remember, the person that is stronger goes at the head end of the stretcher. Person that is not that strong, foot end. Strong metal frame to which all other parts are attached. Hinges at the center allow for elevation of the head and back. Some used to have the ability to elevate the lower extremity as well, but I'm not sure if they make them that way because it's not something that is encouraged anymore. It has guardrails to prevent the patient from rolling out or rolling off the stretcher. Now, you need to be in physical shape, good physical shape, or well, I should say ideal physical shape. You don't need to be super fit. It is important that you are able to maneuver a stretcher with up to 250 pounds on that stretcher, not by yourself, working with your partner. And you will be tested on that when you come face to face. Come for your face-to-face evaluation. Once you have a patient that exceeds your weight and your partner's weight combined, then you're going to need additional help, right? Don't try and move that patient. Now, what I always do, or I always think about is if I cannot touch the opposite side of a patient, so if I can't stretch my arms across and feel the opposite side of a patient, or if I have to stretch too much to reach the opposite side of a patient, I'm gonna need assistance to move that patient. Once I can comfortably reach over to the opposite side of the patient, I'm able to manage that patient's weight or use that patient's weight to assist me to move them, which I'll show you that practically when we have our face-to-face session. So a lot of the movements is really using the patient's weight to your advantage. Now, the wheel ambulance stretcher also have an undercarriage frame which allows adjustment to any height. So it has a lock which can release, you can release and then adjust the stretcher to any height that you want. Well, not all stretchers are like that. The older modules can only go from a high position to a low position. The newer ones, you can adjust it to various heights depending on where the patient is and where you want the stretcher to be. It has a mattress, which must be fluid resistant. The patient is secured with straps and you have different strap system. Ensure that you're familiar with the one that your organization use. And the purpose of the straps is to help to protect the patient from further injury. Now the backboards. The backboard is a long flat device and it is made of rigid rectangular material, mostly plastic. It is used to carry and immobilize patients with suspected spinal injury or other trauma. It is a device that, yes, you need to be familiar with, but just understand that it is being phased out. So we're gonna get to the point where spine boards are no longer carried on the unit. And most services now don't have spine boards on the unit. But the spine board, think of the spine board as a full body splint. So when you make a decision to use your spine board, you're really thinking about the entire patient. It's a full body splint. So if a patient is critical and that patient has a lower extremity fracture, I'm not going to waste time splinting the patient's leg when I can put them on a spine board that's a full body splint. Or I can use their good leg to stabilize their injured leg. So it's a full body splint. The preferred spine board is the scoop spine board. And the scoop spine board is a spine board that can be pulled apart into 2 sections. That is ideal. To manipulate a spine board, at least 4 persons are required. So if you are making a decision to use a spine board, you will need additional help. So if it's 2 of you working on the unit, you're gonna need additional help to move the patient effectively. At least 4 persons are required. Still on backboards, commonly used for patients found lying down. Used to move patients out of awkward places. It's 6 to 7 feet long. Holes serve as handles and as place to secure straps. Now, moving and positioning the patient. When you move a patient, take care that injury does not occur to you, your team members, or the patient. So instructions must be clear. Designate appropriately. Put the strongest upper body, second strongest mid-region, weakest at the legs. Patient lifting and moving are technical skills that require repeated training and practice. Using proper body mechanics and maintaining physical fitness greatly reduce the chance of injury. So if you didn't really consider being in good physical shape, it's time, especially if you're working in a service that's active. Move patients in an orderly, planned, and unhurried manner. And this is something I always say to students and EMTs. You will never see me running to any patient. You'll never see me running to move a patient, right? That's not a wise thing to do. Because when you make a decision to respond, when you're responding, I should say, not making a decision. When you respond, there are equipments that you have to carry to where the patient is. You can't run with equipments. And if you run with those equipments, when you get there, you're gonna be breathless. You're gonna be focusing on controlling breathing. Your speech pattern is not gonna be very clear. That's not wise. And you're putting yourself at risk to fall. I will walk briskly, but I'm not gonna run to any patient. If they have been stabbed, they have been stabbed. If their leg is fractured, leg is fractured. If they're in cardiac arrest, they're in cardiac arrest. Me running to that patient is not gonna change the outcome. It might even make it worse. So that's not wise. So orderly, plan, unhurried. Give clear instructions. We will move on 3. Look before you start, because sometimes persons are not in the correct position. Sometimes persons' hands need to be adjusted. So pay attention. Once you're leading the call, pay attention to what is happening. Master the skills necessary for the equipment you will be using. So know everything about the equipment. Proper body mechanics, very important. Now, the most important thing that you need to know as it relates to body mechanics is we do not lift with our back. So your back is not designed for lifting. So we don't bend our backs to lift. Weight management is based on our legs. So your back must always be upright and in a straight position, and you use your legs to maneuver or carry the weight upwards. Now, lifting position. The shoulder girdle should be aligned over the pelvis. Shoulder girdle should be aligned over your pelvis. So you shouldn't be leaning forward to lift any patient. Hands should be held close to legs. And you keep, when you're holding with your hands, it's palm up power grip, equal distance between the hands. And the closer your elbows are to your body is the stronger your grip will be. Once your elbows start to extend, your arms are going to get weak. So you need to be close to the weight, as close to the weight as possible. And I always get close to the point that my elbows can touch the outside of my abdomen. That's how close I get to the weight. That means I have perfect control of that weight. Now, once you have locked your elbows in, do not allow the weight of the stretcher to pull you off balance. Sometimes I observe that happening when the students lift the stretcher. The weight starts pulling them forward. Lock your elbows and you lift. The force then goes essentially straight down the spinal column. So we don't want the force moving in the spinal column with the spinal column bent. That's how you're going to get injuries. And back injuries are career-ending injuries. These can turn into chronic problems. Now, proper body mechanics, and even in this picture that is depicted, even though they're showing the correct thing in this picture, the person in this picture his back is still too curved. The back need to be straighter than that, much straighter than that. You may injure your back if you lift while leaning forward. Protect your back. Your back is not designed for lifting. There are exercises to make your back more flexible and to develop the back muscles, but it's still not designed for weight bearing. If you lift with your back straight but bend significantly forward at the hips, can cause injury. Now, lifting technique. Legs should be spread about 15 inches. And I always say outside either at your shoulder width or a little outside of it. Place feet so that the center of the gravity is balanced with your back held upright. Bring your upper body down by bending the legs. And this is where persons have problem because they don't have strong legs. So it's difficult for them to squat and keep the back straight. An exercise that you can practice is you put your back directly against the wall and you squat. Now, if you move down in a squat position and your back is off the wall, that's poor positioning. So you need to get accustomed to squatting and your back remains straight. That's what you want. Now, once you're in proper position, then you can grip your stretcher appropriately. Lift the patient by raising your upper body and arms and straightening your legs until standing. Keep the weight close to your body, elbows close to your body. Once your elbows start to extend, your grips and your arms are gonna get weak. So if you have to extend your arms to hold the stretcher to move, you're not in a good position. Keep your arms the same distance apart. The power grips or power grip gets maximum force from the hands. It's palm up, hands about 10 inches apart. All fingers are at the same angle. Fully support the handle on the curved palm. And whoever is controlling the lock to release the stretcher to adjust the height is the person that is going to give the count. Now, once you have control of the lock to release the stretcher, if a patient or any weight is on the stretcher, do not play around with the lock unless the stretcher is being supported. So if no one is supporting the stretcher, don't play around with the lock. Once the locking lever is released, you must anticipate weight. So you cannot pull the locking mechanism and you're not anticipating weight coming down on your fingers. You have to anticipate weight coming down once you have released the lock. These are mistakes that assist students make when they come for this practical. So fully support the stretcher, especially if someone is on the stretcher. When directly lifting a patient, tightly grip the patient in a place and manner that will ensure that you will not lose your grips on the patient. Now, principles of safe reaching and pulling. Body drag. The same body mechanics and principles apply to moving, lifting, and carrying a patient. Keep your back locked by tightening your abdominal muscles. Kneel. Extend your arms no more than 15 to 20 inches in front of you. Alternate between pulling the patient by flexing your arms and repositioning yourself. To drag a patient across a bed, kneel on the bed to avoid reaching beyond the recommended distance. Drag the patient to within 15 to 20 inches. Complete the drag while standing at the side of the bed. Use the sheet or blanket under the patient rather than dragging the patient by his or her clothing. And I will always go for using a sheet or blanket once I find a patient on a bed. That's the easiest way to do it. In the hospital, transfer the patient from the stretcher to a bed with a body drag. The stretcher should be the same height or slightly higher than the bed. You and your partner should kneel on the bed and drag in increments. Do not rush. There's no need to rush to get the patient off if it's going to risk you injuring yourself or injuring others. Right. Now, the log roll. To log roll the patient onto his or her side to place a patient on a backboard. I've mentioned this before. If you are considering to use a spine board, the minimum is 4 persons. It can be more, but it shouldn't be less than 4, especially if you have a patient with some size on them. Kneel as close to the patient's side as possible. Keep your back straight and lean solely from the hips. Roll the patient without stopping until the patient is resting on his or her side and brace against your thighs. Pulling toward you allows your leg to prevent the patient from rolling over completely. I'll show you this technique. Now, what is important to remember here is that the person who controls the head of the patient is going to give command as it relates to the log roll. The person that is in the mid region or mid portion of the patient will control the spine board, and they can do so from opposite sides, so they don't necessarily have to be on the same side as the other rescuers. They can be on the opposite side. Whenever possible, use a device that can be rolled. When a wheel device is not available, make sure that you understand and follow the guidelines for carrying a patient on a stretcher. Now, patient weight. Estimate the patient's weight before lifting. Adults often weigh 120 to 220 pounds. And estimating the weight of the patient might not be that valuable to you, because some persons might not look like they're heavy, but they're actually pretty heavy. So really, for me, and I'm not saying you should do this, but for me, as I said, once I can comfortably reach across that patient and touch the opposite side, I should be able to move that patient with the assistance of my partner. If I can't, I'm gonna need help. And I've had a patient that is so big that I needed a mini crane. I might be exaggerating a little bit, but I needed a device to lift her and move her to where the stretcher is. And it was her device. So it's not a device that we had on the unit. It's something that she has to move around. I don't understand how some persons get so big. It's almost unbelievable. 2 EMTs should be able to safely lift this weight. And if you and your partner can't safely do it, don't put yourself at risk. Try to use 4 providers to lift when possible. This will provide more stability and less strength is required. Do not attempt to lift a patient who weighs more than 250 pounds with fewer than 4 providers. Know the weight limitations of the equipment and how to handle patients who exceed weight limitations. And again, don't rely too much on estimation of the weight. Some persons might not tell you their actual weight. And I've had a patient where the patient stepped on the scale and the scale couldn't give a weight for that patient. The scale just could not find a weight for this person. Now, know the weight limitations of the equipment and how to handle patients who exceed the weight limitations. In up-to-date and good EMS systems, they have a bariatric stretcher and a bariatric unit. So if we go on a scene where a patient is more than what we can manage as a team, we can request a bariatric unit, and they'll come with a special stretcher and other resources that can aid in moving this patient. Might not find that available in Jamaica though. So again, if there's no safe way to do it, don't put yourself at risk. Your personal safety will always come before the patient. Lifting and carrying a patient on a backboard or stretcher. More of the patient weight rests on the head half of the device than on the foot half. The diamond carry and the one-handed carry is used. 1 EMT at the head and foot, and one on each side of the patient's torso. I actually prefer 2 EMTs on one side, 2 EMTs on the opposite side. So I'm not a fan of the diamond carry because the person that is at the front is gonna be in a very awkward position to move. So I prefer 2 EMTs on each side. So we can lift like that and make adjustments. So 2 on one side, 2 on the other is perfectly fine. But if you prefer the diamond carry, go ahead. But that's not something I would be using. Lifting and carrying a patient on a backboard or stretcher, use 4 providers, 1 provider at each corner of the stretcher to provide an even lift. That's the method I use. So 2 on one side, 2 on the other side, we lift and we turn. I use a single grip and we move. That's the best way to move with the spine board. I prefer that over the diamond carry. When rolling the wheel ambulance stretcher, make sure that it is in the fully elevated position. And once you're adjusting the height of the stretcher, ensure that it is locked in position. Now, moving a patient with a stair chair. This is a very useful device. So this is a device, a stair chair is used to carry conscious patients up or down a flight of stairs. This is a lightweight wheel folding chair, and it has molded seat, adjustable safety straps, and a fold-out handle or fold-out handle bars, which aid in lifting the patient. Very, very good device to have on your unit. Absolutely wonderful device. Will get you out of a tight spot. If you don't have a stair chair, then a chair might be the option, but you're gonna have to strap that patient down on the chair. So it might be better to push your organization to get that stair chair. Now, regardless of whether you're going up the stairs or down the stairs, the patient head will always be upright. So whether you're going down or up, the patient's head will always be upright, not pointing towards the ground. To safely move a patient in a stair chair down a stairs, 3 persons are needed. 1 to control the head portion of the stair chair, 1 to control the leg portion, and a spotter, someone to stand behind the person that is controlling the leg to let them know when a step is there. So that person will stand behind them to reinforce their body weight and indicate when they need to step. Step, step, stop, hold on, adjust, step, instructions. So at least 3 persons. Moving a patient on stairs with a stretcher. A backboard should be used instead for a patient who is unresponsive. It must be moved in supine position, must be immobilized. Now, again, just like the stair chair, if you are going to be moving with the spine board up or down a stairs, patient head must always be upright. Weight control must be appropriate. You may have to use somebody to reinforce body weight as needed, depending on how much space you have to maneuver. Still on the stair chair, carry the patient, what am I saying? Moving a patient on the stairs with a stretcher, really the backboard we're focusing on at this point. Carry the patient on the backboard down to the prepared stretcher. Place the strongest EMTs at the head and foot ends with the taller person at the foot end. Place both the backboard and the patient on the stretcher. Secure both to the stretcher with additional straps. Easier said than done, right? So again, the most important thing is to ensure that you're in proper position, grips are good, don't rush. If you need to take a break, take a break. You need to pause to make adjustments, pause to make adjustments. Loading a wheel stretcher into the ambulance unit, ensure the frame is held firmly between two hands so it does not tip over. Newer models are self-loading, allowing you to push the stretcher into the ambulance. So the more newer stretchers, they actually, once you push it into the unit, you just press a button and it loads itself. We don't have that in Jamaica. So you will have to guide the stretcher in, and if you're guiding it in, weight is on the stretcher. So you have to control that weight. You can't make the weight pull you forward. Other models need to be lowered and lifted to the height of the floor of the ambulance. And once it's into the ambulance, it's going to be locked into position. Ensure that it's locked in position. If it's not locked, it's going to be shifting all over the place. You don't want that occurring with your patient, especially a patient that's critical. Directions and commands. Team actions must be coordinated. Team leader indicates where each team member should be, rapidly describes the sequence of steps to perform before lifting. Preparatory commands are used. Example, team leader says already to stop. To get team's attention, team leader says stop in a louder voice. Countdowns are also used. Carefully plan ahead. Select the methods that will involve the least amount of lifting and carrying. Consider whether there's an option that will cause less strain. Always. Now, emergency moves. An emergency move is necessary when you arrive on a scene and there is a danger to you, the patient, and your crew. And this is before you do any type of assessment on the patient. So you have not assessed the patient, you have only assessed the scene. You need to move that patient quickly. Excuse me for a bit. You need to move that patient quickly. So that would be an emergency move. Now, what I always tell students is that all drugs are emergency moves. So all drugs are emergency moves. Underarm drug, clothes drug, blanket drug, firefighter drug, these are emergency moves. So again, an emergency move is necessary when you arrive on the scene and there is danger to the patient, you and your crew members before you have assessed the patient. So you're moving the patient because there is danger. Now, use techniques to help prevent aggravation of patient spinal injury. Clothes drag, blanket drag, arm drag, arm to arm drag. These are all emergency moves. And I prefer B, A, well, I prefer B, A, and D, but all can be applied. I'm just telling you what I prefer. to remove an unconscious patient from a vehicle alone. So you can also use an emergency move. So the first situation is there's danger to you, crew, and the patient. A second situation in which you can apply the use of a emergency move is if you come on a scene, let's say it's a motor vehicle accident, or there are two patients. The patient closest to you is stable, but the one beside that patient, the stable patient, is not. You can use an emergency move to move the stable one out of position to get to the one that is unstable. So to remove an unconscious patient from a vehicle alone, move the patient's legs, clear off the pedals, rotate the patient so the back is toward the open car door. Place your arms through the armpits and support the head against your body. Drag the patient from the seat to a safe location. So if you have a patient in a vehicle and there is danger, you can use an underarm drag. It's really an underarm drag you're using, and pull that patient out as quickly as possible. Now, naturally, if you can wrap your arms around that patient, you can't move the patient. So it would be outside your capabilities. So know what you can and cannot do. Now, the depiction in A and B, I would do it a little different. So when I get my arms under the patient arm, I would grab the opposite hand. So I would use my right hand to grab their left arm and use my left arm to grab their right arm and pull the arms closer to the body. That is going to aid me to move the patient better. Now, an urgent move. An urgent move is when you come unseen, and this is actually the one that, okay. An urgent move is when you come unseen, you have started your assessment, right? So you have started your assessment and you realize that your patient is critical. LOC is altered, they're not breathing properly, they're showing signs of shock, there is extreme weather condition present. You're gonna use an urgent move to move that patient. And this is actually the move that you would use to move the patient that is stable, get to the one that is unstable. So this is actually, I was mixing it up with the emergency move. The emergency move is only when there is danger to you, crew, and patient. Urgent move is after an assessment. Emergency move is before an assessment of the patient. And one of the most common examples of a emergency move is something that we refer to as rapid extrication. So we find a patient in a motor vehicle accident. Patient is not stable. You're not communicating with us. We can use a rapid extrication to remove that patient out of the vehicle. That would be an urgent move. Rapid extrication technique should be used only if urgency exists. The patient can be moved within 1 minute. This technique increases the risk of damage if the patient has a spinal injury. Look at all options before using an urgent move. Team need to be properly trained in this technique. So it's a procedure that needs to be practiced regularly. I would say at least every month if it's a busy service. If it's not, at least every 3 months, you should be practicing rapid extrication. If it is within your organization protocols, because it's really something that firefighters that are EMTs would be doing. But an EMT will play a part in how a patient is rapidly extricated. It has to be persons that have EMS training. But firefighters are also going to play a role because they are responsible for creating access. They will assist with some of the lifting and stuff like that. Now, non-urgent move. A non-urgent move is when your patient is stable. So this is when you have time to decide what's the best method to move the patient from point A to point B. The patient is stable. So use when both the scene and the patient are stable. Carefully plan how to move the patient. Team leader should plan the move. Team leader should be thinking about how many persons will be required. Will there be any issues? Any type of equipment needed? Any special procedure? Any specific path that needs to be taken with the patient? Stuff like that will be the team leader's responsibility. Now, let's look at these non-urgent move. And there's a large amount of emergency moves. So there are quite a lot of options for you. So you have direct ground lift for patients with no suspected spinal injury or supine, patients who need to be carried over some distance, EMT stand side by side to lift and carry the patient. So you have a direct ground lift. That's an option. You have extremity lift for those patients with no suspected spinal injury who are supine or sitting, helpful when the patient is in a small space. One EMT is at the patient's head, the other at the patient's feet, and the movement is coordinated verbally. Transfer moves. So these are moves to transfer patient. You can use a direct carry. Move supine patient from bed to stretcher using a direct carry method. You can use a draw sheet method, which is my favorite. Draw sheet method, move the patient from bed to stretcher using a sheet or blanket. And you can use your scoop stretcher. Or orthopedic stretcher. Now, geriatrics. Most patients transported by EMS are geriatric patients. Skeletal changes may cause brittle bones, rigidity, and spinal curvatures that present special challenges. Allay the patient's fears with a sympathetic and compassionate approach. So some patients may have abnormal curvature of the spine, kyphosis, and lordosis. When these patients are on your device, you may have to consider putting padding wherever there is space between the patient and your lifting device. Or you may have to make adjustments based on how they are positioned on your device. Now, bariatric or bariatrics refers to management of obesity. 76 million US adults are obese. 30 to 40% of adults are obese. Approximately 17% of children are obese. So US definitely need to think about why that is the case. I don't think we don't have that issue in Jamaica. So you're not gonna see a lot of obese patients in Jamaica, but may come across a few, especially in the States. Back injuries account for the largest number of missed days of work. Stretchers and equipment are being produced with higher capacities. Does not address the danger to users of the equipment. So even though the stretchers are more high-tech, manpower is still needed when we have a bariatric patient to move. Mechanical ambulance lifts are uncommon in the United States. Additional patient moving equipment, bariatric stretcher. So this is what a bariatric stretcher looks like. Specialized for overweight or obese patients, wider wheelbase for increased stability. Then you have your pneumatic and electronic powered wheel stretcher. So this is the most modern stretcher. This is the one that you can press a button to adjust the height. You can press a button to load the stretcher into the unit. It limits the risk of injury to providers and patients. You have your portable folding stretchers. You will see these a lot out here. JDF uses these stretchers a lot. And these stretchers are necessary in areas where your wheel stretcher would not be able to move, or it might not be appropriate for you to use. You may have to leave the wheel stretcher at a location and then put the patient on a portable folding stretcher and then get them to the wheel stretcher. The flexible stretchers. This is for high angle rescue, patients that need to be kept in supine position, useful for confined spaces. So it's excellent for storage and carrying, conform around the patient's sides, useful for confined spaces. Then you have your short backboards, and you have your KED, which is the same as a short backboard. So you can have a short backboard, or you can have a Kendrick extrication device, and it is also being phased out. It's a device that is used to move a patient from a motor vehicle accident that is that is not unstable. That's the purpose of the KED. Moving a patient from a MVA that is not unstable, but they may be having issues moving on their own. But it's being phased out because most system now is, if it is a patient in a motor vehicle, it's either self-extrication or rapid extrication. That's the direction that most services are going in. The KED, Kendrick extrication device, can also be used to stabilize a fractured pelvis, and it can be used to stabilize a fractured femur. All right, now vacuum mattress. Pretty useful device. Definitely useful for your geriatric and pediatric patients. So we don't want to put these patients on rigid backboards. The vacuum mattress is a better option because it conforms to their body and it puts less pressure on their skin. These patients have their skins break down easily if they're too flat, and they're having breathing problems that can cause the alveoli to collapse, which is not good for these patients. Air is removed from the device, allowing it to mold around the patient. It provides immobilization, comfort, and thermal insulation, which is very important to the pediatric patient. Now, the basket stretcher. very useful stretcher as well. It's a rigid stretcher used for patient removal in remote location, including in water rescues and technical rope rescues. If the patient has a spinal injury, secure the patient to the backboard and place it inside the basket stretcher to carry the patient out of the location. When you return to the ambulance, lift the backboard out of the basket stretcher and place it on the wheeled stretcher. Now, the scoop stretchers or orthopedic stretchers. This is what is taking the place of the spine board. It splits into 2 or 4 pieces. Pieces fit around the patient who is lying on a flat surface and then reconnect. So you're scooping the patient. Both sides of the patient must be accessible. The patient must be stabilized and secured on the scoop stretcher. And you have scoop backboards and you have scoop stretcher. Neonatal Isolate. Neonates cannot be transported on a wheel stretcher. So the isolate keeps the neonate warm and protects the child from noise, draft, infection, and excess handling. The isolate may be secured to a wheel ambulance stretcher or freestanding. Now, decontamination. Decontaminate equipment after use for your safety, the safety of your crew, safety of the patient, and for preventing the spread of disease. Patient positioning. Proper position depends on the chief complaint. So how you position your patient on your stretcher will largely be based on the patient presentation and their chief complaint. A patient reporting chest pain or respiratory distress should be placed in a position of comfort, typically Fowler or semi-Fowler's position. A patient in shock should be placed supine. A patient that requires upper airway management, you want the patient in a supine position. Patients in late stages of pregnancy should be positioned and transported on their left side, and that's very important. And because when they're close to full term, if they are placed in a supine position, the weight of the pregnant uterus will come down on the major venous vessels on the right side. So it can obstruct the veins, the vena cava on the right side, which reduces the venous return to the right side of the heart. So it can cause supine hypertensive syndrome. We don't want that for a pregnant patient, because when the patient is pregnant, if there is any complications to that patient and they start to go into shock, their body will protect them. It will not protect their fetus. An unresponsive patient with no suspected spinal injury should be placed in the recovery position once they have visible chest rise. A patient who is nauseated or vomiting should be transported in a position of comfort. Very important information. Now, medical restraints. Evaluate for correctable cause of combativeness. So if the patient is combative, think about injury or medical condition that can cause the patient to be combative. And if it is present, address it. Follow local protocols. Restraint requires 5 personnel. Restrain the patient in a supine position. Positional asphyxia may develop in prone position. So don't put them face down. They can suffocate. Apply a restraint to each extremity, assess ABCs, mental status, and distal circulation after restraints are applied. Document all information. Now, personal considerations. Questions to ask before moving patient. Am I physically strong enough to lift or move this patient? Very important question to answer in your mind, not out loud. Is there adequate room to get proper stance to lift the patient? So do I need to move the patient, then lift the patient? I've had a patient that had a seizure. So the patient had a seizure in the toilet, right on the toilet, him have a seizure. So when I got there, he was inside. A part of him was outside the door of the toilet. The other portion was inside. So he was kind of in a Fowler's position, right? He was snoring. So he was in the postictal stage. And based on that, I knew that I needed him in a position where I could properly assess his airway. So I couldn't properly assess his airway like that. So I had to move him from the position that he was in to a supine position where I could properly assess his airway. So sometimes you may have to do that. So look at the environment. Do we have enough space to work based on what is wrong with the patient? Can I leave the patient in that position, or do I need to adjust the patient position to give the most appropriate treatment? Do I need additional personnel for lifting assistance? Injured EMTs cannot help anyone, right? So a dead EMT is of value to nobody, and an injured one becomes a nuisance. Always make sure that you do what is best for you and your crew members in terms of safety. Your safety comes first. And that would bring us to the end of this chapter.